Hello, everyone. I'm Kelly Lendvoy, VP of Communications Public Affairs at Arthritis Consumer Experts, and we are at the Canadian Rheumatology Association and Arthritis Professional Association's annual scientific meeting held virtually this year from Quebec City. And one of the really fortunate things for us attending this conference is we get to meet some really cool, smart clinicians and researchers from across Canada. One of them is joining us today, Dr. Elizabeth Hazel. Dr. Hazel, welcome.
Thank you so much. It's great to be here.
Dr. Hazel is an associate professor of medicine at McGill University, has been the head of the Young Adult Rheumatologic Diseases Clinic, also known as YARD, for the last 15 years. She's also program director at McGill from 2012 to 2021. As part of our CR Arthritis, we like talking to experts like you, Dr. Hazel, about their fields of study. And so we're particularly interested in finding out today what you can share with our audience about the experience for young patients who are transitioning from pediatric to adult rheumatology care. I guess to start off, what is the difference between pediatric and adult models of care for arthritis patients in Canada?
Yeah, so even though we have great pediatric rheumatologists and amazing adult rheumatologists, there's a big difference between the care models in pediatrics and adult systems. The pediatric models are really family-centered. And what you see if you look at the statistics is that the average visit in a pediatric rheumatology clinic lasts longer. There are more people in the room, and the decision making is much more of a shared decision between the parent, the child, and the adult. The other big difference is the access to allied health. Any parent who's brought their child into a pediatric rheumatology office may have seen the physiotherapist or ergotherapist and probably has pretty good access to a nurse. On the adult side, it's much more difficult to get that kind of support service.
So that support is so crucial, but obviously not all patients receive it. So I'm wondering, how many young patients get lost in that transition process?
Yeah, so that was exactly the question I had 15 years ago when I decided that this was going to be the focus or niche of my career. And I conducted a project with Sarah Campillo at the Children's, and we wanted to look at exactly that. How many kids get lost to follow up in the transition period? And the first thing that we did was we looked to other specialties. There was more research in the fields of type 1 diabetes and transplant care and that kind of thing. And we were shocked to see the high numbers of loss to care in these serious diseases like renal transplant. About 50% of kids were lost to follow up in that era. When we looked at our own data in rheumatology, we were surprised to see that those numbers were pretty similar. About 50% of kids are lost to follow-up. Now, that was a definition of not seeing a doctor for about 2 years. And you can imagine in a kid with a kidney transplant, that could represent losing that organ. For our patients, maybe not quite as severe, but it could represent some major damage to their joints. So this was what we decided that we were going to tackle, finding ways to improve this transition period.
And I think for our audience who might not be familiar with when we're talking about the transition process, this is for young patients who, have turned 18 and over the next few years, let's say from 18 to 25, who are facing all sorts of challenges in terms of moving into adulthood. This would just be another compounding issue and a very serious one. And obviously, not everyone is going to be able to handle that transition as successful as others.
Yeah, so one of the interesting things that we found was that in general, kids that were diagnosed when they were very young, professional chronic disease patients that have known only about arthritis since maybe they were 2 years old, actually fared better in the transition period than those that had been diagnosed just, at 15 or 16 years old. And that it was all new for them, and they were trying to deal with accepting all the burden of having a chronic disease at the same time as, finding a date for prom and having their first drink of alcohol maybe, and all this kind of thing at the same time.
So YARD, your program at McGill, has seen thousands of young patients go through. You've had a tremendous impact on their lives. What can you just tell us a little bit about that experience? How does YARD work?
Yeah, I don't know that we're quite up to 1,000, but we do take most of the patients that graduate from the Montreal Children's, and a few that come from Saint-Justin as well. So yeah, this has been a true quality improvement type project. The way it started, we tried certain things, and every year we look back on what's working and what's not working, and it's really been a project in evolution, and we've made changes up until even the last 6 months. Our current model is that of a two-phased transition. And I partner with an amazing group of healthcare professionals at the Lethbridge Leighton Mackay Rehab Center. And the reason I do that is, it goes back to your first question. I don't have good access to physio, OT, social work, and these really important allied health professionals at the hospital. So the way it works is that for their very first transition visit, the young adult, often accompanied by a parent, will meet with my YARD coordinator, who's actually a physiotherapist by training, and my social worker and myself, and we'll just have a first 1-hour meeting where we get to know how they're doing, what their goals are, what their barriers are. And then after that sort of meeting where we've discussed the evolution of their disease and how it's been affecting them, they have evaluation meetings with occupational therapy, physiotherapy, and a career counselor. After all that, we have a multidisciplinary meeting, and we hear about the goals of that young person, and we see if there's a program that we can develop for them or services that we can offer that they're going to help them in the short term. About a few months later, depending on how active their disease is, I'll see them for their first medical visit at the hospital. And what's amazing about that is that I already know who they are a little bit. I've already met them. I know, what they want to be when they grow up. I know that they have a sister that annoys them at home, and then I can talk to them about how their methotrexate's going, or how their injections are going. And we can focus on the medical side of things. And I know that I have that background support of the Lethbridge team, at least in that early transition period.
You've really established a best practice for the rest of Canada. And I guess with the theme of this week's annual scientific meeting in our heads, and the whole issue around, or issues around, health inequities, I'm wondering about the standard of care across the country, but particularly for Black, Indigenous, peoples of color, LGBTQ communities who face challenges within the healthcare system that a lot of us others don't. What is that? How is that delivery working for those people in the country?
So first of all, I'll talk about how it's working well. And I think that the bottom line to addressing a lot of those issues is patient-centered, individualized care. And, having access to a social worker who can actually drill down and see if there are financial, social issues that haven't been addressed, that's a huge benefit. And, just having that extra time and the team approach and the support can make a big difference. Now, on the other hand, this full transition service is not really offered to my Inuit and Cree patients that are living in remote communities. We have to there modify and find ways of combining, co-managing with their family doctor, and the story gets more complicated, as you can imagine. But as I said, this is a project, and we're always in evolution, and we'll find ways to make it better for everyone every year.
So if a young patient is entering the transition or is in the transition process and have some questions, where can they go for information?
Yeah, so the wonderful thing about our online world these days is that there's so much more support. One of the groups that I'm most impressed with started in BC. It's called Cassie and Friends. And there's a podcast, and there's a lot of information out there, and they're starting to move into French as well. So it's one of the resources that I point my patients towards. And the other one of the other things in Quebec, at least, that some of my young adults have had access to are the arthritis camp system. So they've got to meet other people with their diseases. So, I think that peer support is super important in these conditions.
Thank you very much for speaking with us today, Dr. Hazel, and joining our CR Arthritis program at the annual scientific meeting this week. I didn't mention it in your bio, but as you're focusing on the workshops this week, your attention probably is also in Beijing, because you're a former Olympian yourself, an Olympic swimmer. So you must be sort of having divided loyalties this week.
Yeah, I did get up and watch the opening ceremonies this morning, and it was beautiful. I do feel for the athletes not having quite as much freedom as I definitely had in Barcelona. And yeah, I'll be cheering for those Canadian women hockey players who have been taking no prisoners. And I think Michael Kingsbury is going for gold in the moguls tonight. So go Canada, go.
Go rheumatology, go Canada, go. Exactly. Thank you again, Dr. Hazel.
All right. Have a great day.
Bye-bye.